Good morning, everyone. I'm Neil Love from Research to Practice, and welcome to What I Tell My Patients. As this morning we talk about the management of hepatobiliary cancers. We have a great faculty today, and I'm really looking forward to making rounds with them, hearing about their patients and about some of the new clinical research coming out in this field. These are the themes that we get into in this series. Most importantly, this is really a clinical research update. What's been going on in the past year that's important in terms of new treatments, new FDA approvals, and where things are heading. And then the whole issue of patient education and trying to explain what's going on to patients, and particularly to adapt to their biopsychosocial needs in doing so. And finally, we talk, and I think it will become evident as we talk about the real patients in the practice of our nurse practitioners on the faculty, the bond that occurs between the health caregiver and the patient and family, and how important that is to the patient. And finally, to say to you all, thank you very much for an incredible job that you do. Your work is highly, highly valued. So with that, we're going to kind of jump into the meeting. We like to introduce the faculty by giving them the opportunity to tell us a little bit about themselves. I asked them to talk a little bit about what they do to get away from the job, something that's very important for all of us. Are you new to oncology? I think one of the key ways to avoid burnout and other issues that occur is to just kind of get away from things. So I'll start out with you, Ahmed. Well, what do you do for fun?
Yeah, so outside work, I enjoy martial arts, and we do that with my family. We're all black belts in Taekwondo, but I always throw some jokes with my friends and my team that we took an oath not to use our skills outside the Taekwondo floor.
Wow, I never would have guessed that. Dan?
I'm a big foodie, so I like to go all across the city, whether it's hole in the walls or fine dining and everything. And I actually ended up choosing my medical school purely because of that. So I went to New York City.
Wow.
And Cornell, and my attempt was that I was going to eat at a different restaurant every single day during my medical school. And unfortunately, I failed miserably because I did not realize how many restaurants were in New York City.
Very interesting. Mandy?
So I am a mom to an almost 10-year-old girl. She takes up most of my time with soccer, Girl Scouts, all of the things. But we have a boat, and we like to get out and go boating with friends and family and just try to escape. Ultimate dream is to have a lake house somewhere in retirement.
Yeah, so we hear a lot about kids and pets here. Blanca?
What I do to get away is I really enjoy cooking. I unfortunately cook like I'm feeding an army, but the good thing is that my colleagues get to reap the benefits.
That sounds good also. All right, well, here's where we're heading today. We're going to cover hepatocellular cancer, primary cancer of the liver, and then in the first half of this, in the second half, really a cancer that we've been hearing more and more about the last few years. Very, very interesting biliary tract cancer. So we're going to get into that, not only chemotherapy, immunotherapy, but really interesting targeted therapy of biliary tract cancers, which has really come on in the last year. So we're going to start out with a case in a second, but we have to first ask our docs about a paper that was just presented in the last couple weeks, American Association of Cancer Research, for the first time ever in hepatocellular cancer, Ahmad, adjuvant therapy, a positive trial. So these are people who have had primary resection of their liver cancer or hepatic transplant who are given atezo-bev, as you all know, a very common combination in the last couple years in advanced disease. And Ahmad, the results were, quote, positive, but I'm not sure they're positive enough to get people to actually want to do that. What were your thoughts about it?
Yeah, so the study met its primary endpoint, as we call it, which is recurrence-free survival. But the enthusiasm has been dampened a little bit because the data was a little bit modest, in terms of the difference in both arms. The big advantage is we're very used to this regimen. We've been doing it for years. So we're waiting for the data to mature, for the FDA official approval. So we haven't been doing it yet off-label. We're waiting for the FDA confirmation of the clinical benefit.
We were talking a little bit about this because this is really big news now. Everybody's been waiting for this to get presented. about whether or not it's really going to be enough for people to really advise it to patients whether the FDA is going to approve. And this is another theme that we're getting into all week. What does it take for a trial to want to use a therapy? This does have some benefit. We'll talk about the downside of therapies like atezo-bev, but the relative risk reduction was not as great as people hoped. It was, around, I think, 25-30%, which is, a positive study. Ahmed, but any thoughts about, we were talking about yesterday morning in our program of diffuse large B-cell lymphoma, same thing, big trial, about the same benefit that they saw, but this was substituting one thing for another. Here, we're talking about using a therapy that usually people would not get. So again, Daneng, I guess another issue would be, in terms of primary attempt to cure HCC surgically, if they go for a transplant, so either they're going to get surgical resection or actually a liver transplant. But if they get a liver transplant, they're going to be on immune suppression. They won't be able to get atezo-bev. Any comments on that about using checkpoint inhibitors in people who've had transplants?
In general, we avoid checkpoint inhibitors and immunotherapy post-transplant because, of course, the risk of the rejection in those patients. And we rely on mainly targeted therapies, so anti-VEGF, and also some tricks we do with the transplant teams in terms of what immunosuppressive regimen to use, because some of them had anti-cancer effects. Actually, there is also an area where it's like pre-transplant. Those patients waiting for the transplant to happen, bridging to transplant. What would you do if they're still waiting a year and a half for transplant? So there are some studies looking into that. One of them with immunotherapy to do it, just stop beyond 6 months and stop, so that way you have at least 3 months before transplant for the washout. So it's a very active area of research in this interesting and very dynamic era of immunotherapy. We're trying to find room for all patients in all settings.
So we'll see how this evolves. I guess by this time next year, we'll have a lot more feedback on whether or not the FDA approves it, and whether this is an attempt to try to cure people. This is not palliation. So people have to look very, very carefully when we talk about improving cure rate. Just one more thing before we start getting into these cases, Daneng, could you kind of paint a little bit of a picture of where we are today in terms of hepatocellular cancer? Sort of what are the routes that people take to get there, so to speak? We have people who have a history of cirrhosis, hepatitis in many situations. Now we have another set of people with so-called NASH. Can you talk a little bit about the types of people, patients who get HCC?
Yeah, I really think we have a very different dynamic throughout the world, right? Usually in the eastern part of the world, it's really predominated still with hepatitis B, whereas in the western part of the world, it's really more hepatitis C as well as now NASH cirrhosis. So I think, particularly in the United States, where there's a kind of this growing trend of people getting liver cancer as a result of non-viral etiologies, it's really important to keep in mind to have these patients meet with their primary care physicians, meet with hepatologists, undergo the routine traditional screening methods that we have, whether it's with ultrasound or additional imaging, so that you can actually pick up the liver cancer relatively early. Like as a medical oncologist, unfortunately, a lot of my patients I see really have advanced disease, and while we made headways in terms of our treatments, in terms of how long we can extend the amount of time that they live, they're not curable. So if we can catch that disease relatively early, like Ahmed said, we're able to potentially now have possibly adjuvant treatment that can potentially cure these patients of the disease. So I would emphasize, tell your patients to get those screenings and meet with their doctors at a very early stage so that you can catch that disease very early.
Yeah, that's a really good point. But Mandy, unfortunately, most of these patients present with non-curative situations, either extensive disease in the liver that precludes surgical cure or metastatic disease. Clearly, if they have metastatic disease, they're going to be treated like people with metastatic disease in general, get systemic therapy. We'll talk about that. But one other important issue that comes up in these patients, Mandy, and I'm sure you see it every day in your patients, are people who have disease that's confined to the liver, but they're not curable. And the question are you going to use systemic therapy, or are you going to use therapy inside the liver directly, almost similar to, we were talking last couple of days ago about a patient presented with metastatic breast cancer. Are you going to use systemic therapy that also will affect the primary, or actually local therapy? How do you go about making the decision if the disease, Mandy, is confined to the liver about whether you're going to use intrahepatic therapy or systemic treatment?
So at our institution, we do have a liver tumor board that meets a group of hepatologists, surgeons, medical oncology, radiation oncology. And obviously the surgical patients, those are the ones that have a good liver reserve, not cirrhotic. They're able to have surgery. So then patients that aren't surgical candidates, most of the time, if they do have localized disease, they do end up treating with local regional therapy first, whether that be with Y90, which is radiation, versus TACE, so arterial chemotherapy. Then they often come to us kind of to be on standby for when to kind of pull the trigger for systemic therapy. But I don't know how everybody else is seeing this, but I oftentimes will see these patients after they've had these local regional therapies and their liver is somewhat fried. They have more liver dysfunction. Their biliary or bilirubin is elevated. They may have worsening of their cirrhosis as far as ascites or other symptoms, which then kind of limit our systemic therapy options.
So Ahmed, that's sort of a story I've been hearing for a long time from medical oncologists. You know, by the time I see the patient, the interventional radiologist has already used a whole bunch of therapies in the liver, and the patients now have very poor liver function. What am I going to do? I want to give systemic therapy. When we started to see, in the past, we really didn't have good, we had tyrosine kinase inhibitors that really didn't usually cause tumor response. But now the regimens we're using, atezo-bev, durvalumab, they will shrink tumors. Have you seen a shift more towards systemic therapy, or do you still see these people who are getting, particularly in the community where we don't have these great interdisciplinary conferences and the interventional radiologists sort of do their own thing? What do you think is going on nationally right now in terms of this question, Ahmed?
Yeah, so it's really changing fast. I would say not even the last, 5-6 years, but the last couple of years. So everybody's realizing, including patients and treating physicians, that the options for hepatocellular carcinoma are expanding by the day. In some certain cases, we're seeing a lot of those data coming from immunotherapy studies and so on. So we're seeing this shift and this more and more collaboration, multidisciplinary, like Amanda was saying, in terms of liver tumor board, even the community setting. They call us, they talk to us about the patients. Should we start with local therapy, or have you guys start systemic first? Should we do them together? So there is a lot of these discussions happening nowadays, even at the community settings level, because people realize that systemic therapy nowadays is much more effective than it was even 5 years ago, and they realize the importance of the multidisciplinary management. So this is all to the benefit of our patients.
Dan, can you talk a little bit about the types of intrahepatic therapies that are used and what kinds of complications you see with them?
Yeah, so there's a wide variety of liver-directed therapies that can be used. So there's, for relatively small tumors, a lot of times we'll just use ablation, where you're burning off the tumor within the liver. For larger tumors, there's either different types of embolization modalities, where essentially you're blocking off the arterial blood supply that's feeding the tumor, because the tumor essentially preferentially feeds off of the arterial supply, and then your normal liver can still function through the venous supply that's provided in the liver. So here, there's kind of 3 different modalities. There's what's known as bland embolization, where you're using essentially just regular beads to block off that artery that potentially feeds the tumor. There's chemoembolization, where you're essentially eluting the beads with some chemo to further block and burn off the blood vessel that's going to the tumor. And then there's radioembolization, where you use essentially radio beads that's a little bit more diffuse and can hit a larger area. These are essentially all equivalent in terms of what we know. I think the concern is overall in terms of how big of an area that you're ultimately treating. As Amanda said, when you are treating a large amount of tumor within the liver that many of these patients might have, the concern is that, are you going to hurt the regular parts of the liver And we know that these patients already have a lot of scarring of the liver in terms of their cirrhosis. And then can you make that cirrhosis worse with these different types of embolization procedures?
This is really maybe a unique situation in medical oncology where you have really two different, really potentially lethal processes, cirrhosis and HCC, that you can really get ahead of one and the other one kind of comes up, and so you're constantly, really also the value of having a hepatologist as part of the team. All right, let's hear what happens in real life, because it's never as simple as it seems on paper. And Blanca, you have a 68-year-old man, and when he got to you, again, like a lot of these patients, he's already had a bunch of local therapies, but there's always something different about taking care of patients that makes it different. And I guess one of the things you were talking to us about before we came in here was that this man had a long history of depression that preceded even the development of HCC, and that was really part of taking care of him, was that issue. Can you talk a little bit about your first encounter with him and sort of what's been going on? I see he got atezolizumab, the checkpoint inhibitor, and bevacizumab, probably the most common first-line therapy right now at this point. What happened?
Yeah, so when we first met and discussed his systemic therapy, it was, first of all, he's Spanish-speaking only, and so is his caretaker. So really the importance of doing the education in his native language and providing the educational material in his native language. I am fortunate that I am bilingual, so I was able to do it myself and not have any of that education be lost in translation. Additionally, the importance of establishing the baseline so that we know when he deviates from his baseline, such as his underlying comorbid condition, specifically his underlying depression. Because of his underlying depression and can mimic any potential immune-mediated adverse effects from the atezolizumab. The other thing that was important for me is that the patient and his caretaker understand basic mechanism of action of his therapy, because if they understand the basic mechanism of action of the VEGF inhibitor, the immunotherapy, then they're going to understand why it's important that we have this prompt communication and early intervention. And so he did have a deviation from his baseline. The depression did get a little worse, and so then we had to intervene and use a multidisciplinary team approach.
Interesting. So I'm curious, what were some of the things that you kind of went through with him and maybe his family when he started on atezo-bev? One of the things we're trying to get into is really what people say to patients, and we kind of been avoiding slides because you don't have slides when you talk to patients. We've had some great examples. I think it was yesterday somebody was comparing a scene in Lady and the Tramp to when they have bispecifics. Anyhow, I like colorful examples. What were some of the things you went through with him, particularly the issue, well, both with the atezo and the bev?
So it was important that they understand that there can be these immune-mediated adverse effects, and how does that happen? How does that occur? And what I like to give them as a basic concept is that we're stimulating the immune system, therefore we can have these immune-mediated adverse effects. These are large words. We're using different verbiage, so I really try to simplify it and try to make it in terminology that they can understand, that we're enhancing the immune system, and the immune system can sometimes go awry and start attacking itself, start attacking their own body. So the importance of going head to toe, where are you at baseline and how do you deviate from baseline? And so that they documented, that we documented together, and if we need to go through it together to assist them to document it for them, that we do that. And as well with the bevacizumab, there could be the hypertension, the proteinuria, and that we establish where are they with their hypertension at baseline. Some of these patients have underlying hypertension that is untreated, or because they're overwhelmed with their underlying malignancy, that they forget to continue to treat their underlying hypertension. And so going through every single individualized potential baseline and how they can be affected by their ongoing therapy, and the importance of addressing and communicating early for early intervention.
So Dan, I guess it's been about a year now that we've now had another alternative to the atezo-bev regimen. When that regimen came out, it was really exciting. We started to see responses for the first time in this disease. And then we saw another paper with a different strategy, and this was all immune. So no bev, no anti-angiogenic, just 2 checkpoint inhibitors, anti-CTLA-4 and anti-PD-1. A lot of you have heard about ipilimumab and nivolumab, that's anti-CTLA-4. and PD-1. This is a different, similar combination, tremelimumab, again, anti-CTLA-4, and durvalumab, PD-1. One of the issues, Dan, is when you give Bev, specifically in a patient with cirrhosis, you have to rule out varices. So these patients may need to get scoped. They have to, if they have varices, it needs to be controlled. What is the rationale behind that, Dan? And in general, first of all, what are patients where you don't want to give Bev, even beyond esophageal varices? And what do you think about this new regimen? Have you been using it?
Yeah, so I think the durvalumab and tremelimumab regimen is a really good alternative regimen for us to have for those patients that are not able to potentially tolerate bevacizumab. As we discussed, whenever we're talking to our patients, we have to tell them about potential side effects and risk. And one of the risks with bevacizumab is this risk of esophageal bleeding. And that's why they have to get the upper endoscopy prior to the start of treatment to minimize that bleeding risk. So for those patients that are found to have very large varices, either large esophageal varices that maybe previously bled before, or gastric varices that are very often at high risk of bleeding, then those are really not good candidates for bevacizumab treatment. So having a immunotherapy only or IO only approach is really important in these patients. And I tell them, hey, with this combination of durvalumab and tremelimumab, you have a certain percentage of patients that can do really well on that regimen with a prolonged dose. And I would say one of the other major advantages that can be considered with this treatment is the fact that some of the comorbidities that we'd like to avoid with bevacizumab-associated therapies, such as the hypertension or risk of stroke, the thrombosis events, don't happen with that regimen. So these are really kind of sometimes are older adults, and one of the benefits of the durva-tremi regimen is that the tremelimumab in this regimen is only one dose. So they take one dose and then they're essentially maintained on the durvalumab dosing every 4 weeks. So a lot of our older adults actually like that because they don't have to come back to the clinic so much, and it's fairly well tolerated in that sense.
So Ahmed, one of the themes that we're getting into this week, and really patients who are interested, and you may have patients who are oncology nurses or oncologists. So if people want the information, one of the key issues that comes out as oncology all the time is you have two different studies of new therapies, but they're not compared to each other. They're compared to the standard of care. So yesterday in our CLL program, we were talking about all the new trials. You have ibrutinib, the BTK inhibitor out there. That was a baseline. And now new BTK inhibitors, and they compare them to the old, so to speak. But often you don't have the comparison of the two. So we don't, Ahmed, have a direct comparison between atezo-bev and durva-tremi. We kind of look at them separately. They're different studies. And obviously, if they can't get Bev, it's great to have an alternative. But, we had the principal investigator of the durva-tremi trial. He said he thinks this ought to be given to everybody. And it's kind of hard to argue because you don't know for sure which one's better. How have you been thinking it through, and how your colleagues at MD Anderson, what the first therapy is going to be?
Yeah, this is a very, very common scenario, and I have to tell you, even though we look at it with some, inherent bias as physicians, some of us will have better experience with certain regimens than others, but we go back to exactly what Blanca was saying, personalizing the approach to this very specific patient. And I have to say, our nurses are a very, very integral part of this, multidisciplinary management and how to get to know our patients better, because they get so personal with our patients. They are the first ones to meet with them, and patients feel very comfortable with them. As clinicians, we tend to just, talk business. We walk in, we have the scan results, we have the labs, and we just start talking. But our nurses give us the first impression of the day about this patient. How are they doing? Oh, they lost a loved one. They have some depression, and they're not eating well. All of these things that could get missed. So I have to say, our nurses are very integral to this decision-making because they help us understand the full picture that patient, and then we personalize our management. Like Dan said, if you're worried about certain side effects in a patient, maybe we can do the durva-tremi because it's just one dose of tremelimumab. However, if you have a patient who's like marathon runner, you're looking forward to hopefully shrinking the tumor and taking them to surgery, maybe you should use the atezobev because it has higher response rate. So that's how we take those decisions in a team manner.
Interesting. So, Mandy, one of the things, again, that we've been talking about in assessing a patient, kind of figuring out, as we were just talking about, sort of where the patient is at. What are some of the things you're thinking about when you go in and meet for a patient and family? I'm not going to say whether they're going to be a good patient, but whether they're going to be able to, do what you need them to do, call you when you want them to call them, really be a partner. What are some of the things you look for when you first meet a patient?
So my role in seeing a new patient is really to get a very good history, find out, are they at risk for bleeding? We always kind of have the discussion, are they going to be a bleeder or not? So, find out if they've ever had any hospitalizations for GI bleed, do they have a history of varices? Also, when considering immunotherapy, do they have any autoimmune problems that are not well controlled, or something that if we started immunotherapy, we could rev up and actually cause things to worsen? Have they had a prior transplant? These are all things that you have to consider when thinking about these medications. Also looking at their performance status. Are they still functional? Are they still able to take care of themselves? Are they still able to use the restroom by themselves? Go shopping, go to church, see their friends, family, things like that. Also, in this population, you may have a history of patients that have had hepatitis or alcohol abuse. And could have had history of IV drug use. I have a patient with that history, and compliance is also going to be something that we're looking at when discussing choices of picking therapy. Are they going to show up? Are we going to need to get social work involved in helping make sure they even have a ride to come to the clinic to get their treatment, and just making sure the community resources are there to help them out.
Blanca, what have you observed in terms of quality of life in these regimens? First off, have you actually used the durva-tremi regimen, or all your patients so far getting still atezo-bev? And what do you observe quality of life like? I mean, if you think about it, this is not chemotherapy, so what do you see quality of life like? And have you used the durva-tremi regimen?
I have not used durva-tremi as of yet. Atezo-bev is the main regimen that we use in first line, and quality of life is actually quite great. Patients tolerate therapy very well, and as long as we again do the education and do the symptom management up front, do the appropriate evaluation up front with the esophageal varices, quality of life is actually quite great.
All right, well, let's get another picture of this from Mandy. You have an older patient now, 79-year-old man. Interestingly, NASH cirrhosis. Incidentally, had he been diagnosed with NASH cirrhosis previously, or that was part of the diagnosis when he had the HCC?
I think he knew he had NASH, but I don't think he necessarily had any kind of follow-up for that. But presented with abdominal pain and was found to have a large HCC, as well as was diagnosed with cirrhosis at the same time. He initially was able to get local regional therapy. I believe he had Y90, but I can't remember. And then he came to us when he developed metastatic disease to the bone and adrenal glands. So he is 79, but he is very active. He is the mayor of his small town, and he is also a pastor at a local church. So very busy, still very active, great performance status, had a great supportive family. He tolerated first-line atezo-bev very well. He has a history of hypertension, but his blood pressure was well managed throughout. He's the type of guy that gets up every morning, writes down his weight, his blood pressure, his blood sugar, and his heart rate, and brings it to me to clinic every time he comes in to see me. So I can very closely monitor his blood pressure. Last spring, he did develop disease progression, and we discussed second-line treatment with lenvatinib. His liver function was still excellent. Blood pressure was well controlled. But because he's 79, we kind of planned initially for a dose reduction in the lenvatinib. So typically for patients that weigh greater than 60 kilograms, the starting dose is 12 milligrams. But for him, we went with the dose of 8 milligrams, which is for patients that weigh less than 60 kilos. So when he initially started on treatment, he did not tolerate it. He got very confused, he lost weight, he was extremely fatigued, and this was probably only within taking it for 2 weeks. So we ended up stopping treatment for a couple of weeks to let him recover and resumed at a dose reduction of 4 milligrams, at which he tolerated very well with no side effects initially.
Interesting about the fact that he's a pastor. I don't know to what extent you talk to him about his spiritual beliefs, but just curious, does he share it with his the people in his congregation?
You know, I'm not sure if he does, but it did definitely make an impact when we had that discussion that cancer was progressing. He kind of took it in stride and, kind of relied on his faith very heavily to kind of, he's like, oh, this is just what is part of my journey, and I'm going to go ahead with the next step. And, he felt like it was in God's hands and didn't really necessarily get overly upset or anything like that during the visit.
Yesterday we actually, in the diffuse large B-cell program, we had a patient who was a Jehovah's Witness who completely, refused blood products, and he had potential life-saving therapy that he was. It's interesting that we have that privilege of being able to interact with people in that situation. So and you were saying he had hypothyroidism also? Yeah,
so when he was on the 4 milligram dose, no side effects, but things started to grow a little bit, so we'd escalated the dose back up to 8 milligrams just to see if he would be able to tolerate it. And fortunately, he did. He did not develop any of those recurrent symptoms he had at the beginning. But when patients are on lenvatinib, we do have to monitor thyroid function because it can cause hypothyroidism. And we slowly started seeing a tick up in his TSH. He was also letting me know, I am feeling more tired. He could still do everything. He was still doing both jobs, but just was feeling more fatigued. And as that started going up, we did end up starting thyroid hormone replacement.
So I shouldn't admit this, but when we were in the faculty room and we were talking about this case, and Mandy said, he got hypothyroid. I'm like, hypothyroidism from lenvatinib? And everybody goes, yeah, of course. I'm like, I never heard of that. We talked about it a million times. We never talked about it. So, and I was asking Dan, maybe you can talk a little bit about what TKIs are, what lenvatinib is. Sorafenib is another TKI, and how they get hypothyroid, if it's known.
Sure. So, lenvatinib is part of this group of medications that are known as tyrosine kinase inhibitors. So they inhibit a specific pathway that's oftentimes involved in very angiogenic tumors, so tumors that really derive benefit from creation of blood vessel formations. And these are a group of medications that we traditionally will use in liver cancer as well as other cancers like kidney cancer oftentimes. And as mentioned, one of the side effects of these medications is this phenomenon of hypothyroidism, and it can certainly happen with either lenvatinib or other tyrosine kinase inhibitors that we use, like cabozantinib, sorafenib, regorafenib for HCC. So traditionally, what we've been able to do, in practice, is that many of these patients will get a check in terms of thyroid function tests about every 6 weeks when they're on these treatments, and this is a good way to capture this potential side effect phenomenon. We don't necessarily know why these medications can have this impact on thyroid function, but certainly that is true and everything. So it's really good to monitor in that sense.
And it is a very common complication of checkpoint inhibitors, and it's very important to follow thyroid function in a patient is on a checkpoint inhibitor. I'm curious, Ahmad, we have a thing in oncology that the first sort of treatment that comes on board, everybody gets used to it, and they don't want to change unless something looks a lot better. Here we have an alternative that came up later in the first-line setting, durvalumab. People are already getting used to atezo-bev. We were talking Wednesday night with breast cancer, the 3 CDK inhibitors. The first one that came out was Palbo, so everybody get used to using that. They didn't want to change the others. Have you actually used the durvalumab regimen? And what's your take, of course, when you use, as Dan was referring to, when you use ipi-nivo, we see definitely more, problems with autoimmune toxicity. But this regimen has less of the anti-CTLA-4. Indirectly, it looks like a lot less need for steroids, maybe half the need of Ipi/Nivo. Have you actually tried the regimen, and any thoughts about toxicity?
Yes, so I've done it in a significant number of patients. Those patients basically who look a little bit more fragile, to us, that we're worried about their tolerance to atezolizumab and also lenvatinib, as Amanda said, these are not benign drugs. And there are some, studies, also some evidence of the durvalumab study that shows they use what we call ALBI score, albumin and bilirubin score, and patients who had lower hepatic reserve, defined by the ALBI score, they still tolerated and had better, outcome compared to the standard of care. So I use it in those patients who are borderline liver functions, borderline performance status because of the tolerance issue. And I totally respect and understand Amanda's point about the pastor, their patient, to start with lower dose. So the same concept, goes to the core of and the heart of managing your patient in a personalized manner. So one time our nurse was, participating in the discussion regarding which regimen to use, and she pointed out that this patient is a pianist, and he's really scared about something that could give him some, difficulty with using his fingers. So we're avoiding TKI because of the hand-foot syndrome. So all of these things really are critical for us to understand the patient as a whole and pick and choose which regimen would be best for their quality of life. And I really think I'd encourage all our nurses to continue to read anything new in HCC, any regimen in any cancer, to read about the side effects and all of these things, because you are part of the decision making as nurses. You are the first in line. And once you get to know the patient the way you do, you know the patient better than us. And we all admit that our nurses know our patient at a personal level. Then you can participate in the decision making once you know the side effect record and all of that, and that way you can participate actively.
Part of the granularity, what we're trying to get to this week, is to talk about the fact that a lot of times really important decisions are being made, and it's not that clear what the best choice is. So if the patient wants to be involved, here you have two very different therapies. I'm curious, Daneng, again, have you used the durvalumab regimen? What's your take on the tolerability? Any thoughts about, okay, fine, if they can't get Bev, but there are people who just want to use this regimen rather than atezo-bev. Nobody knows the answer. Any thoughts, Dan?
Yeah, so we've definitely used it, and really used it for those patients that had contraindications to bevacizumab. And to Ahmed's point, it's really sometimes for those patients that might want spaced out infusions, and they don't. The regimen allows for infusion every 4 weeks, whereas atezo-bev is every 3 weeks. It might not seem important that it's just a week to all of us in the medical community, but these are patients that are making sometimes their bucket list, right? They want to be able to travel, they want to get away, be able to see the world and everything. And I think we have to keep that in mind. So whenever we're talking to our patients, it's like, what is your goal? What are you trying to achieve? What are those milestones that you really want to hit? And I think that's important in terms of also choosing the regimen that you're going to use.
Mandy, what was your take on your pastor in terms of what was important to him? And also, I'd like to hear your experiences with lenvatinib. Yesterday, the gynecologic oncologists, you can talk to all day long about lenvatinib and endometrial cancer. They all argue about what dose to use, how do you follow the patient, hypertension that can occur very quickly within the next few days. They all have their different procedures to make sure that these patients are followed. So first of all, what was important to your pastor, and how do you follow people who are getting lenvatinib?
So maintaining an excellent quality of life, being able to be there for his congregation, and still, not only be there on Sundays, but he does like hospital visits and at-home visits. So being able to still be active was extremely important to him. So when discussing lenvatinib, kind of a broad spectrum of side effects that can happen when they start this medication. Fatigue is very common. So in his particular case, wanting to maintain that good quality of life, being 79 years old, we thought, we're not going to start with the 12 milligram dose. We're going to start with the reduced dose and see how he tolerates it. So fatigue, nausea, vomiting, diarrhea are common. So just making sure they have those antiemetics on hand or antidiarrheals if needed, how to use them, and when to call us. So if those symptoms are not controlled with supportive care, they need to call us. Do we need to give fluids? Do we need to add additional medications to help? Do we need to hold the dose based on the toxicity? Monitoring, very closely monitoring their blood pressure, because that is a very big side effect of the lenvatinib. Watching their protein levels in their urine. We explained that protein can spill in their urine, so typically, once a month when they do come in to see us, we do get a urine sample. Don't necessarily see the hand-foot syndrome and rashes like you would with sorafenib, but it is, possible. We do get a baseline EKG to assess for QTc prolongation. And our pharmacist does a great review of their current medications to see if there's any interactions that could potentiate that risk. And if there is, then we may do monitoring of EKGs more frequently while they're on therapy. When patients initially start these oral medications, we like to see them back in the clinic probably 2 weeks after starting, check their blood pressure, check their kidney function and liver function to make sure everything has been going okay so far.
Anything else about what was important to this man in terms of goals that he had? We've been talking about this the last couple of days, that people who are in situations where they have limited life expectancy still have short-term goals that are important to them, seeing the birth of a child or a grandchild or a wedding, etc. What about this man?
He didn't particularly say anything that way. I just knew based on how busy he was that maintaining that was going to be very important to him. He has told me that being the mayor of their town has become way more stressful than he's ever wanted it to be. So he is planning on stepping back from doing those responsibilities and just focusing on being a pastor.
So let's do one more case of HCC. And I was asking the faculty, do you have people like this in your practice? And they all said yes. So this happens, and this is this is part of being in oncology, maybe the good side. What happened with this 70-year-old man, Blanca?
Yes, so this is a lovely 70-year-old gentleman who had viral hepatitis C that was treated. He was treated with local regional therapy, and then when he exhausted that and was no longer a candidate, he went on to systemic therapy with the TKI. He was on his TKI for probably a little under a year, and he tolerated it not so greatly. And was switched onto monotherapy nivolumab. He has been on the monotherapy nivolumab now for approximately 3 years. When he initially started his treatment, his AFP was approximately about 14,000. It's now normalized. His bilirubin has normalized, alk phosphatase, AST, ALT. He's tolerated therapy quite fantastically. At the 1 year time point with the nivolumab, he did develop diabetes as a result of his nivolumab. And so again, emphasizing the importance of having the multidisciplinary team approach, and now endocrinology is part of that group as well, and following him and managing his diabetes. He is insulin dependent, but quality of life is fantastic, and he's had a response, an objective response on his scans as well.
So Ahmad, we've been talking all week about the fact that, sometimes we present cases that maybe have greater outcomes than you're typically going to see. We're not going to say this happens every day, but again, it seems like everybody sees a couple of people who have these extraordinary responses. First of all, any way to separate out somebody like this who somehow has this great response for 3 years? Do you ever see cures? What is it about the tumor or about them that they have a great response, and then the other 90% of people have maybe some response, but not like that? Why?
Yeah, so that's the million-dollar question, right? So, and we've all have had those cases. My record, I always tell my patients as well, for sorafenib was 12 years, for lenvatinib was 4 years, and for nivo, 3.5, and still going on. So we are doing active research, all of us in academia, to figure out which patient should be, responding better to what. We don't have this answer yet, but we go by what the whole panel were discussing. What is the best for this patient? And if we get lucky, and this patient in particular responds, then we just stick with what we have. And again, goes back to the goals of care. So sometimes I've seen some patients coming from community practice and they change their therapy even though they are tolerating okay and the scans are more or less the same just because of alpha fetoprotein going up, for example, or maybe 10% increase in the tumor. So I never do this. So if the patient is tolerating well, good quality of life, and the change is very little on imaging, or even the alpha fetoprotein is going up, I never change therapy, because if you do, you run into the risk of intolerance and inefficacy. So these things are very critical to understand, and our nurses help us with that too, because if the patients are having their best quality of life, we should have a very high bar to change therapy.
So again, I'm kind of curious what it was like to watch this happen. I imagine when you first saw him, you expected him to be like, I'm sure he expected it himself to go downhill. And now, how is he spending his time? What's it like when you see him in the clinic? I mean, we see disasters and terrible tragedies every day, but I imagine every time this man comes into clinic, you're looking forward to seeing him.
It's quite extraordinary to see his case, and he's just an absolute joy to see every time, because he knows how well he's doing, and he's very thankful and very appreciative every time he comes. When he initially started his therapy with his TKI, his performance status was still an ECOG of 1, but not clinically doing as well, and his family, his support system was there at every visit with him, and now that he's doing great and is tolerating treatment so well, and his quality of life is great, he comes by himself, he drives himself. I seldomly ever see his wife or his children, and maybe occasionally his wife will be on the phone, and he's enjoying his grandchildren, his wife. He lives with his children, his daughter, and they built a little house in the back of their daughter's house. So it's just a great joy to see him, and it's just been quite extraordinary for me to have this relationship with this patient that has done so fantastic, and to see it to come to this point.
So Mandy, one of the things we talk about is how often people say to you, isn't oncology depressing? And, I think that the people who end up going into the field are extraordinary people because of trying to deal with what you have to deal with. But also, you are seeing cases like this. And it's not just checkpoint inhibitors. Ahmad was talking about people who get TKIs. And that, maybe is in the back of your mind. How does it affect you when you see a patient? Well, I hear stories of people who are going to hospice. Now they're walking around feeling good. Of course, yes, very uncommon. But the fact that it occurs, the fact that you go through this experience, I would think affects, when you sit down with patients, knowing that this is possible. Any thoughts?
Oh, yeah. So, I mean, in GI malignancies, you see a range from you're fine, you're going to be just fine, we're just giving you kind of adjuvant treatment, and your cancer will never come back, to you have an incurable malignancy and life expectancy could be less than 6 months. So you do kind of focus in on these patients. I have a very similar case of an 80-year-old gentleman on single agent Nivo who's responded amazingly and is thriving now. So you do hang on to those cases and those patients and experiences to kind of balance the good versus the, obviously not so good.
So one final point before you go on to biliary tract cancers. Dan, I meant to ask before, could you explain a little bit about what NASH is? Because this seems to be, I'm hearing more and more cases like this. We know we're seeing more people like this. Who gets NASH? What is it? And why do they get HCC?
Yeah, so NASH stands for non-alcoholic steatohepatitis. It's really, kind of this fatty liver disease that occurs in patients that's not necessarily related to alcohol. So it could be due to other things, whether it's, obesity might be a risk factor, or diabetes can be a risk factor that's associated. And just like anything else, so when we think about cirrhosis of the liver, anything that can cause inflammation of the liver, whether it's the viral hepatitis or NASH or other other things, those things can essentially cause that inflammation, and that leads to the scarring of the liver and cirrhosis for those patients. So, certainly in the U.S., this is on the rise, and as a result of that, I think we have to keep that in mind when we're seeing our patients, and potentially, even for those patients that don't have any type of hepatitis, get them to get screened relatively earlier rather than later.
Ahmed, the introduction of immunotherapy has really been an amazing development, but I'm still not sure we exactly understand, sort of how it works. Any thoughts about how immunotherapy is actually working and what we can do to improve efficacy? What are some of the strategies that are being thought about to actually improve? We talked about adding a second checkpoint inhibitor. And also there's been questions about, do people respond differently to immunotherapy based on how they get to HCC? Do the NASH patients respond as well as the hepatitis patients? Maybe the viral particles stimulate, more susceptible to immunotherapy. Any thoughts about where things are heading and trying to figure out really how immunotherapy works?
Yeah, that's a great question, and we've learned so much in the last few years, and it came down to a very, very important fact, which is the immune cell infiltration. So it really comes down to this, and we've done studies before surgery to look at biopsy and surgery specimens and see the difference after immunotherapy. So that's why we reached the glass ceiling with one immunotherapy agent, 15-17% response. If you use 2 checkpoint inhibitors, it's about 30%. Even one checkpoint, one targeted therapy, it's about 30%. So we all know that 15-30% of patients is really the max that they're going to respond. And if you look at the pathology slides, guess what? This is also reflected there, that the immune cell infiltration is very intense in about 1/3 of the patients, and these are the patients who have chronic inflammation with hepatitis in particular, so hepatitis B, hepatitis C, while patients with NASH tend to have resistance to immunotherapy. So new research is now being pushed for this patient population. What can we do to lower the resistance? So one of the studies we did at Anderson was to look at some drugs that stimulate the environment, and guess what? Something as simple as ACE inhibitors or ARB, for example. There has been a lot of reports about that augmenting in patients with hypertension. We like to have them on ACE or ARB, drugs, for example. So it goes back to clinical pictures of those patients who may respond. Hepatitis, they respond better. Non-hepatitis progress faster, so we tend to scan them sooner than later. We don't wait for them 3.5 months. We scan those NASH patients 2 months, 2.5 months, because we know that they're going to progress faster than others, and they may do better on TKIs. And end of the day, we have to realize that even though immunotherapy is very tolerable and everything, but these are not benign drugs. And Amanda was talking about a patient of hers who had very bad side effect, endocarditis and all of that before the session. So we always have to make sure that patients realize that even though these drugs are more tolerable than chemo, they could carry some risks, so they have to still follow up with us closely. It's not one of these drugs that they can come every other time or disappear on us. We all know those patients who don't follow up regularly, so we have to realize that we personalize our approach to those patients in particular.
So yeah, and we had a case just presented with diabetes, type 1 diabetes, serious complication that can occur as well. I'm curious, you have like the father of immunotherapy, Dr. James Allison at MD Anderson. I'm curious, I don't know if you've ever talked to him, or curious if what's his hypothesis about how we can go to the next level?
Yeah, so actually one of the studies we did, the study I talked about, the surgical study, he was our scientist on board, and he's the one who taught us that baseline, if you get a biopsy and you see specific cell population, we call it CD8 positive immune lymphocytes. Those are the patients who respond the best. And patients who have very low count of CD8 under the microscope with the immune staining, those patients need more than just one single agent immuno. They have to get CTLA-4 antagonists with PD-1. And also the research going on now are looking at LAG-3 and TIM-3, other molecules that can lower the resistance to immunotherapy. So he's an integral part. Actually, there is an institute named after his name at MD Anderson, and most of the patients we like to get baseline biopsy for them to do what we call immune profiling, and I'm sure Dan and everybody here can relate to that. So that's another thing we always talk to our patients. Our nurse nurses also are very good at that, to let them know how critical it is to get a biopsy up front, because there is a notion about HCC that you don't need a biopsy to get diagnosed. But once they understand that we needed to do immune profiling to learn more about who's going to respond and who's not, even if it didn't benefit them, directly, it may benefit somebody else down the line.
So, in terms of what you tell your patients, one of the things to tell your patients are things are different now than they were even 10 years ago. It's not just chemotherapy anymore. And it's not just checkpoint inhibitors, too. We could talk all day yesterday about CAR T therapy, bispecifics, new forms of targeted therapy, and we're about to talk about biliary tract cancer. Same exact thing has happened there. You've seen targeted therapy come in, just like, is it tonight? This is Friday, right? Yeah. We're going to talk about lung cancer tonight and targeted therapy. Biliary tract cancer, I call that the new non-small cell lung cancer because there are lots of targeted therapy. And now, as of a year ago, again, checkpoint inhibitors on board there. We saw a major trial adding a checkpoint inhibitor to durvalumab, which we've already just been talking about, to chemotherapy. And it's now about, well, really, I guess, standard of care. And here's an example of it. This is a 72-year-old patient of Mandy, who got this new regimen. Previously, gem-cis chemotherapy was standard, and a year ago a trial came out comparing gem-cis, the so-called phase 3 trials that we've been talking about, adding in half the patients got durvalumab, the checkpoint inhibitor, half didn't. And again, it wasn't like a home run, they were all cured, but they definitely did better when you added the IO. And this patient, as you can see, also got targeted therapy. So Mandy, can you talk a little bit about, first of all, how this man presented with cholangio?
So he is a farmer, very independent, strong man who likes to do everything for himself. He presented actually with a cough and shortness of breath, was found to have a large lung mass concerning for lung cancer, as well as a large liver tumor. So his workup obviously included biopsies, and it was determined to actually be metastatic cholangiocarcinoma. And we did do next generation sequencing to find that he did have this IDH1 mutation, which was important for us to have, up front so that we knew after first line therapy, what are other options that we can treat him with. So he initially was treated with gem-cis plus durvalumab. He did okay initially, was still able to be independent, still working on his farm. His sons would just come check on him. He was a widower. But as kind of time went on, started just having just significantly more fatigue, started having issues with anemia, requiring blood transfusions, and he just wasn't doing so well anymore. So we decided to stop the gem-cis and just continue on the maintenance durvalumab. He ended up having to move in with his family because he was so weak that he really wasn't able to care for anything at the farm, let alone himself or his home. And unfortunately, he did progress shortly after we stopped the gem-cis. And then last fall, we started the ivosidenib. And he has actually tolerated it very well. Really minimal side effects up until recently. Started just having more issues with his blood counts, with specifically anemia again. And he does have malignant ascites and is requiring frequent paracenteses now.
So, and Saturday morning we'll be talking about, is that tomorrow? Yeah. I'm like in a fog here, just in the elevator, off the elevator. Anyhow, we'll be talking about IDH inhibitors in acute myelogenous leukemia. And actually, I was thinking about a patient a lot like this man who's on actually the same exact drug that we're going to talk about. So just to take a step back, Dan, can you kind of paint a picture of biliary tract cancers? You have different locations they start. Can you talk about how these patients present, what their usual stages, and particularly what happened a year ago when we now saw a trial, really for the first time in the first-line setting that moved us a little bit head further?
So biliary tract cancers is really I would say a heterogeneous group of disorders. So it really encompasses, gallbladder cancer, as well as extrahepatic cholangiocarcinoma and intrahepatic cholangiocarcinoma. So these are really, what we think, three very distinct diseases. Why do we think that? Well, like you said, Neil, when we look at lung cancer, oftentimes we'll profile these tumors to see whether or not there's certain type of genomic alterations within the tumor. And if you profile a gallbladder cancer versus an extrahepatic cholangiocarcinoma versus an intrahepatic cholangiocarcinoma, you see distinct profiles in terms of what you're picking up. So what that really means is that we really have to kind of individualize our treatment for these patients based off of the location of the diagnosis. Traditionally, they've been lumped together because together they're considered still a rare disease, so there's so few of them. So on a lot of our trials, we had to lump them together to get essentially enough patients to be able to try to test the various different types of agents that we looked at. We really didn't have much for, I would say, over 15 years. It's really been standard chemotherapy with the combination of gemcitabine and cisplatin, and only recently have we had all these other additional target agents, and then more recently, the addition of immunotherapy in the frontline setting with the combination of chemotherapy being able to extend life in these patients. This is really a sneaky disease for our patients because oftentimes I have so many patients that come to our clinic that say, hey, I was feeling great a year ago. I was doing fine. No one suspected this. And then within a year, they suddenly are diagnosed with metastatic disease. And oftentimes they'll just present with abdominal pain, incidentally go to the hospital for that and get a scan, and boom, they have biliary tract cancer. Other times they present with jaundice, if they have any type of biliary obstruction, and then that's what brings them to the hospital. So those are really, kind of the unfortunate, things that we see with this disease.
So Ahmed, when you try to look at these cancers, as Dan was just saying, it looks like it's very heterogeneous. Last night, for the first time here, in all the years we've been doing this for 15 years, we did a program that was not tumor-focused, but target-focused. We did a program on HER2-positive disease. So we had lung cancer people here, breast cancer people here, GI cancer people here. So we were looking at this abnormality across tumor types, which you see more and more in oncology. MSI, another thing we've talked about in several of these programs as well. Can you, again, talk a little bit more about what we know about biliary tract cancers and also the issue of adding in immunotherapy? So we saw this trial a year ago. We'll get back to this case, but using durvalumab, adding it. We saw the FDA approve this strategy, so it was presented I think it was around February last year, and by September, the FDA had approved adding in one. We saw some follow-up data, this is the TOPAZ study, again, adding a checkpoint inhibitor durvalumab to chemo. We saw more data this fall, continuing to show a benefit. What was your take and your colleagues' take, Ahmed, when you saw this data? Was it like, oh, this for sure, we're going to start doing this, this is a new standard of care?
Yeah, so it goes back to what we were talking about with respect to the adjuvant study for HCC. So even though, the study was positive and everything, but if you look at the survival benefit, it was also modest. Here you see, less than 2-month improvement in survival. Actually, just at the AACR also, most recently, another study, GemCis plus pembrolizumab compared to GemCis alone. Yes, this study here, you're reading my mind. So it's very, very interesting how consistent the modest benefit is when you add immunotherapy to GemCis. So this one also less than 2-month improvement in survival. But what both of them did was to validate the fact that immunotherapy also could provide some benefit in those patients, and you could provide some coverage beyond the 6 months of GemCis. We always didn't know what to do. Maybe you could expand the immunotherapy beyond the 6 months. There is still some patients who could benefit from this, but we again have to realize that the 3-drug combo is not like the 2-drug combo. So you have to have good performance status, good liver functions, and so on. on and not just use it because it's a positive trial. And it goes back again to knowing your patients, better through our multidisciplinary approach with our nurses as front line, because we're not going to apply it just because. We have to look at our patient and understand that this modest, improvement in survival don't mean automatically that we apply the 3-drug regimen to everybody. We have to be still very selective.
And actually tonight, and we're going to talk about the same scenario in non-small cell lung cancer. Initially, there was an adjuvant study with another checkpoint inhibitor, atezolizumab, that was positive. Now there's another study with pembrolizumab. And it really, and so you have two, but indirectly, again, same thing, but you don't have a trial comparing the two. So you see one trial, the other trial, which one are you going to do? And it kind of also, Dan, gets into the idea, and you see this all the time with checkpoint inhibitors. When you ask docs, investigators, I'm going to ask you, do you think there's any difference in any of these checkpoint inhibitors in terms of, durvalumab versus pembrolizumab versus atezolizumab? Even there are like 6 or 7 of them. In your mind, have you seen anything that suggests that one is better than the other? And then, in spite of the fact that, I think a lot of people think that they're very similar, usually you use the one where you have the data. It's like you have the trial on this one. It's the same thing, breast cancer. You have 3 CDK inhibitors. There's one that's got a positive adjuvant trial. That's the one that they use. Is that sort of the way you look at this, Dan?
Yeah, for the most part, in terms of the PD-1 and PD-L1 immune checkpoint inhibitors, I would say that from an efficacy standpoint, for the most part, they're very similar. And there's been studies that have been presented by our European colleagues, particularly in lung cancer, where they tested various different types of PD-1 and PD-L1 immune checkpoint inhibitors, and essentially they got the same result. Now, I will say there are certain differences, and we don't necessarily know what to do. So for example, with atezolizumab, which is a anti-PD-L1 inhibitor, there is data showing that there is this phenomenon known as anti-neutralizing antibodies. Now, does that mean that for those patients that develop those ANAs, that they're going to not be as responsive to that treatment going forward as a result of that compared to the other immune checkpoint inhibitors possibly. But still, right now, we're not able to necessarily test those patients, let's say, ahead of time and elicit, what's going to happen to them. We don't know who's going to develop them. In terms of who's going to develop these antibodies and what does that mean. So I would say that's probably one of the major differences. Certainly for other immunotherapy agents in terms of CTLA-4 agents, I do think there is more differences in those type of immune checkpoint inhibitors because of kind of the design of those drugs and how much they can potentially infiltrate into the tumor. So I think there's definitely more differences in that setting.
So I guess another thing is, and I'm curious, again, getting back to Dr. Allison, there's been speculation that maybe the efficacy of checkpoint inhibitors might be affected by the microbiome, the bacteria in the bowel, that somehow that's going to affect checkpoint inhibitors. Curious, any thoughts about that? Do people who are taking antibiotics have less of a response to checkpoint inhibitors, Ahmed?
So there was some reports evolving about this. We did a study in HCC. It didn't pan out that the antibiotic use. Other studies showed the opposite. But for sure, all the studies that looked into the microbiome signature showed a correlation, direct correlation between the microbiome signature, the favorable signature, and the response to immunotherapy. Now, if you look at the microbiome signature itself, in those specific patients, you're going to find out that it's all with the common suspects. So those patients who are eating healthy, exercising, all of that, they have better. So there are studies now, including one at our center, to modify this, to start with the patient eating habits and all of that, try to put them on a favorable diet. High fiber diet is the one that is very consistent. So high fiber diet would improve the microbiome signature. So we're trying to do that in a randomized manner, put patients on high fiber diet and study their microbiome signature changes and response to immunotherapy versus those who are eating their regular meals. So this is one of the things that we also try to do, to have our patients introduce them to our dietitian every time we see a new patient so they can work with them on that, because this part is very consistent.
Really interesting. So another example, incidentally, of following the data. And tonight we're going to talk about locally advanced lung cancer. There was a positive trial using durvalumab. The trial with pembrolizumab was not really positive, so everybody's using durvalumab, even though in their hearts they probably feel that they're very similar. You go with where the data is. Now we've had a year where people have been using durvalumab adding onto chemotherapy. Just 2 weeks ago, now we have similar data. Pembro, are people now going to shift over to Pembro? We'll probably talk about it next year. So in any event, let's get back to targeted therapy, which has really been a revolution in oncology in general, but also has come into biliary tract cancers. And Blanca, you have a 43-year-old woman. We just talked about, Mandy, your case of a patient who got targeted therapy with IDH. This is a patient who got another form of targeted therapy, a young patient, 43 years old. What happened with her?
Yeah, she's a 43-year-old married woman with 2 young children. She initially presented with just nonspecific diffuse abdominal symptoms. She was evaluated and she was unfortunately found to have cholangiocarcinoma. She initially was, and she does have metastatic disease. She was initially treated with Gemcis Durva. She was a little shy of a year, and overall tolerated treatment fairly well, but unfortunately progressed. She, at the initial time of diagnosis, when we obtained biopsies, we did do our comprehensive biomarker testing, and she was found to have an FGFR2 mutation or alteration, and so she was then switched at the time of progression to pemigatinib. So she's on pemigatinib, but it was really important with this particular patient that we do set up the expectations as to what the potential adverse effects can be with the hyperphosphatemia, the stomatitis, the nail toxicities that can be quite cumbersome. It could really affect their day-to-day quality of life, maybe a little diarrhea. These are all very manageable with the hyperphosphatemia, having her observe a low phosphate diet. One thing that I always like to point out is that the low phosphate diet is very manageable and something that can be done, but it can really, if you think about it, we're constantly telling patients eat every 2 hours, calorie-dense meals, but those great nutritious calories sometimes tend to be high in phosphate, like the proteins, the dairy, the whole grains, and that makes it a little challenging. So really emphasizing, how these therapies, although they're manageable, they do affect quality of life. But overall, she's continuing to do well. She has had imaging and she's had a good response. Of course, continuing the multidisciplinary team approach in helping involve the therapist to help her children as well to continue to understand what's going on with her disease process, as this doesn't just affect the patient, it affects the entire family.
So there are only about 45 things that we could talk about based on what you said. I was just sort of flashing on the fact, general medical oncology. You're talking to the group, you guys use these things all the time. They have to deal with everything. I was flashing on this conversation I had with a medical oncologist recently, and we were talking about bladder cancer. I said, well, do you have any questions? She goes, well, I'd like to learn a little bit more about the use of erdafitinib. It's a similar kind of drug using bladder cancer. I said, okay. What else? Well, I'd like to learn a little bit more about how to use the antibody-drug conjugate enfortumab. It also improved in bladder cancer. I said, okay. What else? Well, I'd like to know about the antibody-drug conjugate sacituzumab and how you use that. I go, okay. And then I go, I'm kind of curious. How many times have you used any of those drugs? 0. And that's the way it is in medical oncology. You're constantly using things you've never used before. You all use it all the time. This may be once a year that they're going to need to figure out what to do. So let's analyze a little bit about patients with. Now, we're talking about somatic mutations. These are mutations in the tumor. This is not germline, where every cell in your body has it. For example, BRCA that we've been talking about. So in lung cancer, and also now we're seeing in biliary tract cancers, you have mutations that occur just in the tumor. So Ahmad, what is an FGFR alteration, and what are FGR inhibitors? When are they used? And maybe you can dissect a little bit out, based on this case, some of the issues that come up when these drugs are used.
Yes, so for cholangiocarcinoma, the very unique thing about them is that the frequency of the molecular alterations, so IDH1, FGFR2, we've had the advantage of having biopsies and doing the molecular alteration and sending for all of these foundation 1 analysis and whatnot, whole genome sequencing for cholangio, which we didn't have for HCC. So the data are very abundant when it comes to cholangiocarcinoma and showing 20% range of those alterations. In HCC, it is not the case. It's less than 5%. So when it comes to those drugs, early studies showed major issues with tolerance, and we've learned a lot along the line in terms of hypophosphatemia, thyroid issues, all of that. So even though it is about 20% of patients which is not insignificant number, it is not rising up yet to be in front line, because most of these studies were done in the second and third line after GemCis and whatnot. So up until this point, even when we do it upfront, we don't use them until patients progress in front line. And then once we start it, then it's really an uphill battle there, because most of the patients are not in a great shape like they used to be. So we go, to Amanda's point, we go on lower dose of the drug. We go on very, very close monitoring because of the side effects, not only the symptomatic side effects and constitutional symptoms, but also lab, low phosphorus and others, and potassium. And sometimes we get even nephrology consults, on board. So patients will have to understand upfront that these are not benign drugs because they are oral. And most of the patients have second thoughts. And I always tell them, just as it is our job to tell you what to do in terms of systemic therapy, it is our job to tell you when to stop. Because in some cases, if patients have a performance status of 2 or close to 3, and they harbor any of these mutations, we advise against it. So we always have to be upfront with them. The potential side effects record, those oral agents, I can tell you, half of the patients will have something, and it can alter their quality of life. So even though they are very targeted and everything, but they are very hectic on patients with biliary tract cancer, especially because they are used in subsequent lines of therapy, second and third line.
So can you talk a little bit more, Dan, about what FGR alterations actually are, how these drugs work, and particularly your clinical experience with them, as Ahmad was saying and as we're hearing. And, this is a case in general with targeted therapy. It's rarely so targeted that you don't have any types of tolerability. And really amazing some of the complications you see. Now, we just did a whole program on ophthalmic complications, eye complications of cancer therapy. Now you have hyperphosphatemia, which I don't remember hearing about that as an issue that we have to deal with. Can you talk a little bit about the clinical utilization and also the difference between, we have a couple now approved, is there any difference between them? How do you choose which one?
Yeah, so the FGFR inhibitors are really targeting kind of the FGF pathway, and this slide shows it, very well. So this is the fibroblast growth factor pathway, and there's really essentially kind of these 4 receptors, FGFR1, FGFR2, FGFR3, and FGFR4. So this really, essentially once the tumor has an overexpression of this pathway, it leads down to kind of these downstream pathways, whether it's PIK3 kinase as well as MAP kinase pathway that's traditionally been looked at. There are differences between these FGFR inhibitors in terms of how much they target each of the FGFR receptors accordingly, and that's why it might be able to explain for different types of side effects. We know that, for example, medications that have potentially off target on FGFR1, for example, that can potentially lead to kind of a lot of the hyperphosphatemia complications that we see. Whereas other alterations, let's say for FGFR4, for example, can lead to a lot of side effects in terms of diarrhea that we see because FGFR4 is implicated in bile acid secretion. For these patients. In general, these FGFR inhibitors that we use in biliary tract cancers, and particularly in intrahepatic cholangiocarcinoma, is really targeted and geared towards these FGFR2 fusions. Those are the patients that tend to respond really well, and these are where the indications are. So I would say those are the main differences. So, between kind of the different types of FGFR inhibitors, I think, again, like what we've been discussing, today, really kind of keep in mind what are the different potential side effects we want to avoid in these patients. And that can lead you down the road of whether or not you're going to choose one FGFR2 inhibitor over another. So between pemigatinib, infigratinib, as well as futibatinib, there are those differences in terms of what is the frequency of things like hyperphosphatemia, what is the frequency in terms of diarrhea, and that might be able to guide you between one or the other. And then finally, I would say with futibatinib, one of the interesting things about futibatinib is that it does allow for the ability to potentially rescue some patients that may have developed or had their tumor develop resistance to the initial generations of other FGFR inhibitors like pemigatinib. That there are these kind of gatekeeper mutations that sometimes develop that futibatinib might be able to overcome in those cases. So that might be a potential strategy in terms of how you would use kind of the different FGFR2 inhibitors in your patients.
And incidentally, if you look at a graphic like this and go, what does it mean? Join the club, because I feel the same way. I'm hoping other people, understand it better than me, but I'm into upstream and downstream, and that's about it. Mandy, can you talk about your clinical experience with hyperphosphatemia? I hear that there are dietary issues that come up. How do you manage these people in general? And also, how do you deal with some of the nail issues, Mandy?
So the low phosphorus diet really stresses out some of my patients. I have one lady that she is just obsessed over what time she eats based on when she takes her medications, what she's trying to eat. She's lost weight. So to Blanca's point, these are foods typically dairy, high in protein. So they're having to avoid all of these things. So we really do try to involve the dietitian to give them, what encompasses a low phosphorus diet. We typically, when we start these medications, do introduce a phosphate binder along with the low phosphorus diet to help manage the hyperphosphatemia. We'll see them, like on pemigatinib, we would see them approximately every 3 weeks for each treatment cycle to check labs, and may need to either adjust their phosphate binder if they are having hyperphosphatemia, or may need treatment interruption. And I forget the second part of your question. Nail question, yes. So with the nail toxicity, they can see lifting of the nail bed, and that can be extremely painful. So especially in somebody that's, maybe they type on the computer or they like to knit or sew, that can really interfere with their quality of life. So keeping their nails trimmed short, very clean. If there's any evidence of any kind of looks like it's starting to get infected, we would recommend like a vinegar and water soak. I usually tell them 3 times a day of equal parts water to white vinegar. Soak your nails for about 10 minutes or so, just to kind of help decrease the bacteria presence under the nail beds.
So one more point, getting back to your patient who has 2 young kids. And this, again, has been a theme. We've talked about this in ONS many times over the years, and we've already talked about it a couple times this week, which is patients with minor children or minor grandchildren. And I'm curious kind of what your assessment is of that family, or dealing with a disease with a limited life expectancy.
So her children know at some form that she's sick and that she does have a malignancy. To what extent and the details that I'm not sure, but they are aware that mom is sick.
How old are they?
About 8 and 10. And so they're still fairly young, and they're very actively involved in sports and school. And so she tries her best to push on, as all moms always do, to be heavily involved. And so, which makes it, sometimes a little challenging when, you have these nail toxicities to cook, because it can be quite troublesome. The stomatitis, when you want to be interactive and have a family meal, and you're limited with your diet, and it's a little challenging to eat, even though you're trying to be as proactive as possible. But her children are aware. To what extent, I don't know, but our specialty services are helping with that.
I'm curious, Mandy, do you all have any special services, social services that you refer patients in this situation, and has it been helpful?
Yeah, so we do have a special program that is for children whose parents do have cancer, and we do, try to refer to them, when we need to.
So we're going to finish out with one more case, and we've been talking about the issue of all week, of course, of autoimmune toxicity from checkpoint inhibitors. And Mandy has a case of a patient with very interesting complication, unusual history. What happened with this 70-year-old man? We've been talking about this Topaz regimen. That's what he got, and he got an IO as part of that. What happened?
So this man, 70 years old, he's retired. He has a wife who's had a stroke that he's the primary caregiver for. They do not have children, so it's just the two of them. He called me one day. He had been on therapy, he'd been tolerating treatment fairly well, but called me, said, you know what, all of a sudden, I just can't walk across to go to the bathroom without getting short of breath, and I have this new cough. And it just seems to be getting worse every day. I said, well, we need to get you evaluated. At the same time, they were having some remodeling done and were staying in a hotel, and he refused to leave his wife until he could have her back home. So it wasn't until a couple of days later that he actually presented to the ED with just this horrible shortness of breath, cough. Scan showed kind of these opacities in both the lungs concerning maybe for pneumonia. Couldn't really necessarily tell if it was pneumonitis or not. So he was initially treated with broad-spectrum antibiotics. He required oxygen, never seemed to kind of get better over the course of a couple of days. Also, interestingly, his troponin levels were sky high. So it was determined that he did have immune-mediated pneumonitis and myocarditis. So he was started on high-dose steroids, and we saw significant improvement in his symptoms fairly quickly. Had cardio-oncology following him, kind of monitoring the steroid taper as well, and really closely monitoring his symptoms to get him off of the steroids. We did a very long extended taper because we were scared that if we stopped treatment too soon, everything would just rapidly kind of recur again.
And how's he doing now?
He's doing great. So he did have disease progression very much at the same time as all this was going on. And I was concerned, is this kind of the beginning of, his kind of transition to maybe best supportive care? But he was able to be started on second-line treatment with Folfox, 5-FU and oxaliplatin, and he has been thriving. He's had actually treatment, disease response. Tumors in the lungs have shrunk. His primary liver mass has shrunk as well. He is now starting to deal with neuropathy from oxaliplatin, but in general, he's back to baseline. He's mowing his lawn, which he wouldn't even be able to do last summer. He takes care of his wife, and just his quality of life has he's gained all the weight that he had lost back. He's doing great.
Maybe he got a response, and now he's getting the benefits of it. And, Ahmad, this brings up another issue, and I'm curious, when he got to the ER, did they call you? Did he get a hold of you? Did they know he was in immunotherapy? Because we hear a lot of stories of people end up in ERs. The ER people don't even think about autoimmune problems. Were they on top of it?
Once he was admitted to the oncology service, they did reach out to, his primary attending physician who I work with and said, nothing's getting better. What are your thoughts? We're thinking, steroids, thinking this is IO-related toxicity. And he said, yes, I agree 100%, get started.
Ahmad, when you think about it, checkpoint inhibitors have only been out there really 7 or 8 years, at least in mass. Prior to that, we were using them in melanoma, but it was really when you saw it approved in lung cancer that all of a sudden there were a ton of people getting checkpoint inhibitors. And one of the initial concern was non-oncology people understanding what autoimmune toxicity is. So when they show up in the ER and they're on immunotherapy, certainly one of the things you got to be thinking about immediately is an autoimmune complication. Any thoughts about the non-oncology people taking care of oncology patients and their awareness that immunotherapy is not chemotherapy, Ahmad?
That's a great point, Neil, and it goes back to the fact that 90% of our patients are being managed in community settings. While the whole panel here is big academic centers, 90% of patients are going to small ERs, urgent cares, and we used to have, I don't know if this is still being the case or not, patients will have a card, that I am on this drug and, some link, so people can, so this is very critical, and I really think we should go back to this, old style, old days, methodology. You just carry a card, you go to an ER, you give them the card, I'm on this drug, so that way they can look it up and they can look for because it could be the difference between life and this situation, like this patient here. So if the ER is realizing that this could be immune-related, there is no harm in doing some steroid trial, they could save that patient. So I really think we should go back to the basics there, that those patients are being studied every day now, even though to us it's common sense, it's routine. For people in small ER, in small town, middle of nowhere, it is new to them. So we need to have more education targeted to that very specific issue.
Dan, any comments? I was flashing on a case of a patient who, just as you described, patient in North Carolina who had explosive diarrhea, was admitted to a small hospital. They gave antibiotics, antifungals. The patient came back to the oncologist. The oncologist almost had a heart attack because the patient was on an IO. They never even thought about autoimmune toxicity. It also brings up the importance of education of non-oncology people to let them know about immunotherapy, know them about CAR T therapy, et cetera. Any thoughts, Dan?
Yeah, no, I think diarrhea is really kind of a common toxicity with, IO agents, where oftentimes if they go to, different hospitals, they're getting different things, like you said, in terms of antibiotics or antifungals, because they don't think it's necessarily due to the immunotherapy. And I think even, for us as oncologists, we're getting better at recognizing this. We know that we have to get a handle on these immune-related toxicities earlier and get them under control. So traditionally, while we have kind of an algorithm say, hey, if you have grade 1 diarrhea, we can potentially just support you and see how you do. And then if you develop grade 2 diarrhea, which is more than 4 bowel movements, then maybe we'll initiate some steroids and everything. But really, it's about getting ahead of that. So even a lot of times we might use other immune suppressants relatively early to get control of these diarrhea, because we know that once it takes off, it's going to be very hard for those patients to potentially recover. They're going to be needing a lot longer steroid tapers and everything. And oftentimes, these are the patients that actually get into trouble where we've seen bowel perforations and other things like that. So getting ahead of the game, I think, is really important, going forward.
Yeah, I wanted to just emphasize a point and the importance of patients understanding the mechanism of action and understanding what they're getting. Oftentimes, patients will go into the infusion room and they're getting an infusional therapy and they call everything their chemotherapy, and really understanding what they're getting, that they're getting an immunotherapy or a VEGF inhibitor. Should they go to a community emergency room, that they can verbalize what it is that they're getting, that they will not say, I'm getting chemotherapy, because then the diarrhea will be treated as such, but rather say, I'm getting this treatment that stimulates my immune system, or I'm getting this treatment that causes the vessels that feed my tumor to die off. But, so that they have some basic concept. That is always so key and so important, that my patients always understand what it is they're getting. And if they ever call it chemotherapy, we always have to go through the re-education process. And I always insist that they call it by or have it some basic concept that what they're getting, not chemotherapy.
That's an awesome point. Anyone in the mood for talking about PARP inhibitors and antibody drug conjugates? Come on back at noon. We have a program on ovarian cancer. Thanks so much to our faculty. Thank you for attending. Have a great morning.